Welcome back, everyone, to another Women's Health Diagnosis webinar series. We are into part 4, and today we're going to be discussing urinary tract infections. My name is Heaton, and I am the Women's Health Clinical Liaison. We're going to be reviewing the urinary tract anatomy, going over some terminology today on the different types of UTIs. We're going to look at the pathogenesis, pathophysiology, how UTIs come about, risk factors. We're going to go over signs and symptoms, complications, diagnosis, and treatment. So urinary tract infections have been described since ancient times with the documented description in the Ebers Papyrus dated back to 1550 BC, and it was described by the Egyptians as sending forth heat from the bladder. Effective treatment did not occur until the development and availability of antibiotics in the 1930s, before which time herbs, bloodletting, and rest were recommended. So UTIs are very common in the US, and they are the second most common type of infection in the body. And they're also the reason for more than 8 million visits to the doctor each year. Approximately 25 to 40% of women in the US aged 20 to 40 years have had a UTI, and women are at greater risk of developing a UTI than men. And among adults aged 20 to 50 years, UTIs are approximately 50-fold more common in women. And most of the UTIs in this age group are cystitis or pyelonephritis. The incidence of UTI in women tends to rise with increasing age, and the rates of infection are high in postmenopausal women because of bladder or uterine prolapse, causing incomplete bladder emptying and a loss of estrogen with changes in vaginal flora, notably loss of lactobacilli, which of course allows for periurethral colonization with gram-negative aerobes like E. coli and a higher likelihood of concomitant medical illnesses like diabetes. UTIs account for over 6 million patient visits to physicians per year in the US. Approximately 20% of those visits are to the emergency rooms. Cystitis occurs in 0.3% to 1.3% of pregnancies, but doesn't appear to be related to asymptomatic bacteriuria. Acute pyelonephritis occurs in 1 to 2% of pregnancies. UTIs occur in 3 to 50% of renal transplant patients and frequently are silent. In 2007, approximately 3.9% of office visits were related to symptoms involving the genitourinary tract, and estimates based on office and emergency room visits suggest per annum about 7 million episodes of acute cystitis. And some studies estimate that UTIs, which is cystitis plus pyelonephritis, cost at least $1 billion per year. Okay, so now let's quickly review the urinary tract anatomy. The female urethra is significantly shorter than the male urethra. We're looking at measuring approximately 4 centimeters or 1.5 inches compared to about 20 centimeters or 8 inches in males. Of course, this allows bacteria easier access to the bladder. Bacteria from the external environment can more easily ascend the urethra and cause an infection in the bladder. The female urethra is located in close proximity also to the anus, and this anatomical arrangement increases the likelihood of fecal bacteria like E. coli contaminating the urethral opening and migrating into the urinary tract. Poor hygiene practices or wiping from back to front can also exacerbate this risk. The design of the female bladder and urinary tract means that there are fewer natural barriers to bacterial ascent. Incomplete emptying of the bladder can contribute to residual urine, which provides a medium for bacterial growth. The natural occurring bacteria around the vaginal area and perineum can have higher concentrations of potentially infective agents, especially if there's a disruption in the normal balance of these microbiomes. The urinary tract is divided into upper and lower tracts. In the upper urinary tract, we have the kidneys. They're located on either side of the spine, just below the rib cage. in the back of the abdominal cavity. The kidneys, of course, filter waste products and excess substances like water and electrolytes from the blood to form urine. They also play a crucial role in maintaining fluid and electrolyte balance, regulating blood pressure, and producing certain hormones. The ureters are a pair of tubes that connect each kidney to the bladder, running down the posterior abdominal wall, and the ureters, of course, transport urine from the kidneys to the bladder. And then in the lower urinary tract, we have the bladder here, which is a hollow muscular organ situated in the pelvic cavity, just in front of the uterus and above the vagina. The bladder stores urine until it is expelled from the body, and then it can expand and contract due to its muscular and elastic properties. And then we have the female urethra, also in the lower urinary tract. It is a short muscular tube extending from the bladder neck to the external urethra orifice located anteriorly in the vaginal vestibule, and the urethra channels urine out of the bladder during urination. Okay, now let's get into some definitions and terminology. Okay, now just to have clarity with some of the terminology, we have urinary tract infection, or UTI, which is an infection in any part of the urinary system, including the kidneys, the ureters, bladder, and urethra. Cystitis is an infection of the lower urinary tract, or the bladder, specifically the bladder, causing a syndrome involving dysuria, frequency, urgency, and occasional suprapubic tenderness. Then we have pyelonephritis, which is infection of the renal parenchyma, characterized by flank pain, tenderness, or both, and fever, often associated with, again, dysuria, frequency, and urgency. So there are different types of urinary tract infections. One is uncomplicated urinary tract infection. It's an infection in a structurally and neurologically normal urinary tract of adult females. So current IDSA, or Infectious Diseases Society of America, treatment guidelines limit the definition of uncomplicated UTIs to premenopausal, non-pregnant women with no known urological abnormalities or comorbidities. Asymptomatic bacteriuria refers to the presence of bacteria in the urine without the typical symptoms of a UTI. It is diagnosed when a significant amount of bacteria is found in urine culture taken from individuals who don't exhibit any symptoms of a UTI, like urgency or dysuria, which is painful urination, frequency, lower abdominal pain, etc. And although asymptomatic bacteriuria is highly contagious, in most patient populations, it has not been shown to be harmful. People with bacteriuria are at increased risk for symptomatic UTIs, and treatment of asymptomatic bacteriuria does not decrease the frequency of symptomatic infections or improve other outcomes. Consequently, screening for or treatment of asymptomatic bacteriuria is not appropriate and should be discouraged. So with complicated UTIs, it's an infection of the urinary tract in the presence of factors that can predispose the patients to either persistent or relapsing infections, such as pregnant females, postmenopausal females, children, diabetes, foreign body, such as catheters and other devices, obstruction, immunosuppression, renal failure, renal transplantation, and urinary retention, where it's neurological. And now we're going to go into the pathogenesis, pathophysiology, how UTIs come about. A urinary tract infection is caused by microorganisms in the urinary tract, and most of these bacterial organisms are from the GI tract. And some causative bacteria include E. coli, which is responsible for about 85% or more of cases, followed by Klebsiella species and Staphylococcus saprophyticus. So the colonization of these causative microorganisms of the vaginal opening and the periurethral meatus tissues, coupled with the loss of protective vaginal lactobacillus species. Lactobacillus species provides a low pH, about 4 to 4.5. So it prevents pathogen adherence and bacteriocins. So low lactobacillus species would provide a very good environment for these bacteria to thrive. And lower UTIs affect the bladder and the urethra. Upper UTIs affect the renal, pelvis, and the kidneys. And if it's not possible to differentiate between lower or upper, then it's considered an undifferentiated UTI. Then we have infection can occur via blood or lymph. Sometimes bacteria traveling through the blood or lymph system can cause kidney or bladder infections. Bacteria can be transmitted to the urethra from the bowel, which females are at greater risk due to their anatomy, which we've discussed, and stagnant urine. So urine that's left sitting in the bladder after urination is stagnant urine, residual, that provides an environment for bacterial growth. And stagnant urine residual happens when the bladder is not emptied completely during urination, leaving a small amount of leftover urine. And this provides a wonderful breeding ground for E. coli and other species responsible for UTIs. Okay, so let's go over the pathogenesis of urinary tract infections. We're going to start here. So bacterial colonization begins in the periurethra, which allows for the ascension via the urethra. And then the bacterial fimbria, which are basically short attachment pili, allows for the attachment and penetration of the bladder epithelial cells. And from there, with sufficient bacterial colonization, it leads to bacterial ascension through the ureters. And with bacterial ascension or hematogenous spread, which is basically bacterial spread via the blood to other parts of the body, bacterial ascension and hematogenous spread infects the renal parenchyma and results in pyelonephritis here. And with continuous inflammatory response results in interstitial edema, interstitial nephritis, and ultimately you can have acute kidney injury. And here we have the pathogens that are responsible for uncomplicated UTIs versus the complicated UTIs. And notice E. coli can be responsible for either, just as Klebsiella. E. coli accounts for 85% of community-acquired and 50% of hospital-acquired UTIs. And gram-negative bacteria like Klebsiella and Proteus and gram-positive Enterococcus faecalis and Staphylococcus saprophyticus are causative agents for the remainder of the community-acquired infections. And here are some routes of infection. So in healthy patients, most uropathogens originate from rectal flora and they enter the urinary tract via the urethra into the bladder. And this is the ascending route. And uropathogens initially adhere to and colonize urothelium of the distal urethra. Now, in healthy individuals, infections of the kidney through the hematogenous route is uncommon. Occasionally, the renal parenchyma can be breached in patients with Staph aureus bacteremia or Candida fungemia that originate from oral sources in immunosuppressed patients. And on rare occasions, bacteria from adjacent organs can penetrate the urinary tract via the lymphatics. And conditions associated with the lymphatic route are retroperitoneal abscesses and severe bowel infections. Okay, let's look at some risk factors. So anatomic physiologic risk factors, we discussed the female anatomy and how females have a shorter urethra, 4 centimeters versus 20 to 25 centimeters in males. And then we have vesicoureteral reflux. And this is where urine flows retrograde or backwards from the bladder into one or both ureters, then to the kidneys. So this causes urinary retention and it allows more time for bacterial growth, and it could also allow bacteria to ascend to the kidneys. Pregnancy results in progesterone-mediated smooth muscle relaxation to the bladder and ureters and compression of the ureters by the uterus. Both result in urinary retention for increased bacterial growth. Menopause. When we have a loss of estrogen, there's an increased risk for UTIs. Estrogen helps tissues in the vagina and the urethra to stay elastic and moist. Estrogen loss can thin these tissues and cause dryness, irritation, and other changes that set the stage for UTIs. Estrogen loss weakens the muscle of the urethra, making it easier for bacteria to enter the urethra and move up to the bladder. And estrogen raises the level of healthy bacteria that normally live in the vagina and bladder. These healthy bacteria help fight off infection-causing bacteria. And of course, after menopause, low estrogen just means there's less healthy bacteria to help prevent these infections. Okay, some behavioral risk factors include voiding dysfunction, where it causes increased post-void residual urine volume, which of course allows more time for bacterial proliferation. And frequent or recent sexual intercourse can introduce bacteria into the urinary tract. Genetic risk factors include familial tendency, where UTI occurrence does tend to cluster in families. So mothers, sisters, if they generally have UTI tendencies, then more than likely it's going to be passed on. Vaginal mucus properties. Clinical studies have shown that vaginal mucus can bind bacteria and may influence the initial attachment and subsequent colonization of the vaginal and urinary tract epithelium by E. coli. Iatrogenic or drug risk factors, antibiotic use. Recent antibiotic use can disrupt that normal flora at the vaginal opening, allowing for those pathogens to colonize. Indwelling catheters, like Foley catheters, provide an ascending route for perineal bacteria to enter the bladder. And spermicides cause irritation and attachment sites for pathogens like E. coli. Here are your references. Other risk factors include age 65 years or older with urinary incontinence, urinary retention, numerous hospitalizations and or institutionalizations, a suppressed immune system, whether it be due to diabetes or other diseases that impair the immune system, neuropathy, incomplete emptying of the bladder due to diabetic-related nerve damage, blockages in the urinary tract like kidney stones. Okay, now let's go into signs and symptoms. Some signs and symptoms of bladder infection: pain or burning during urination, more frequent urge to urinate, frequent painful urination, pain in the lower abdomen, pelvic area and around the pelvic bone, pelvic pressure, lower abdomen discomfort, cloudy urine or foul-smelling urine, blood in the urine, and some people may not have symptoms at all. Signs and symptoms of kidney infection: usually you'll see a high fever, upper back and side pain, shaking and chills, headache, nausea, and vomiting. Infection in the urethra, you often find burning with urination, discharge, dysuria, which is pain upon urination, and pelvic inflammatory disease. Now let's go into some UTI complications. Recurrent infections, especially in women who have 2 or more UTIs in a 6-month period, or 4 or more UTIs within a year. Permanent kidney damage from an acute or chronic kidney infection due to untreated UTI. Increased risk in pregnant women of delivering low birth weight or premature infants. Other serious complications include, but are not limited to, renal abscess, where there's a pocket of pus that develops in the kidney tissue. Renal vein thrombosis, a blood clot that develops in the vein that drains the blood from the kidney, or tissue death. Kidney failure leading to sepsis can result in death if there are no medical interventions provided. And if a UTI is left untreated, it can cause death in all age groups. Now to diagnosis. So in diagnosing UTIs, we look for identifying symptoms like dysuria, urinary frequency, urgency, suprapubic pain, feels like prior treated UTI, the absence of vaginal symptoms, the absence of systemic symptoms like chills or rigors, the absence of upper tract symptoms. So the diagnosis of UTIs is primarily made by the presence or typical symptoms and can be confirmed by 2 main lab tests, urinalysis and urine cultures. The advantage of a urine dipstick is that it usually is more readily available than microscopy or culture. The two main tests in urine dipstick that can assist with UTI diagnosis are leukocyte esterase and nitrite. Leukocyte esterase, which is an enzyme that's released by lysed white blood cells, act as a surrogate marker for pyuria, and nitrites in the urine are attributed to the ability of some gram-negative bacteria like E. coli to convert the urine nitrate to nitrite. Positive nitrite on a urine dipstick can therefore be an indicator for the presence of bacteria in the urine, and specifically gram-negative bacteria. But one of the limitations of this test is that it would not detect bacteriuria with organisms that do not have the biochemical ability to create nitrite, such as enterococci and Pseudomonas species. And also, a false positive nitrite can be seen in patients who use phenazopyridine, which is a common over-the-counter urinary analgesic. The reported sensitivity of both leukocyte esterase and nitrite for detecting bacteriuria was variable, but the specificity was found to be more than 90%. Midstream voided urine cultures are a more direct way to assess the presence of pathogenic bacteria in the urine. Bacteriuria in some cases represent contamination. However, in symptomatic patients, this could help confirm the diagnosis of a UTI. The classic cutoff for a positive urine culture to reflect the presence of bladder bacteriuria has been greater than 105 colony-forming units or CFU per ml. And testing with urinalysis or urine culture up front is not indicated in most cases of uncomplicated cystitis. Having classic symptoms of acute uncomplicated cystitis can be sufficient to make a clinical diagnosis and recommend empiric treatment. An example would be a combination of dysuria and urinary frequency without vaginal discharge or irritation, which has a reported positive likelihood ratio of 24 for the diagnosis of a UTI. Patients, especially if they've had prior UTIs, often recognize the symptoms and identify when they have a UTI. So detection of pyuria, so there's no imaging studies are indicated in the routine evaluation of cystitis, but a positive leukocyte esterase dipstick test is sufficient for pyuria in most cases. In females with clinical findings suggestive of UTI, urine microscopy may be indicated, even if the leukocyte esterase dipstick test is negative. Pyuria is most accurately measured by counting leukocytes in unspun fresh urine using a hemocytometer chamber, and having a greater or equal to 10 white blood cells per microliter in urine is suggestive but not diagnostic of a UTI. And the greatest value of checking for pyuria lies in its negative predictive value, which is reported to be more than 85%. So without pyuria, it's unlikely that a patient has a UTI. Other findings, microscopic blood is found in about half of cystitis cases. A positive nitrite test is highly specific for UTI, but it occurs in only 25% of patients with UTI, and low-grade proteinuria is common. Urine culture remains the standard for the diagnosis of UTI. Urine cultures are recommended in patients with probable cystitis if any of the following is present: advanced age, recurrent infection, recent antibiotic use, recent urinary tract instrumentation, such as catheters and immunosuppression. Other diagnostic considerations: occult pyelonephritis occurs in 15 to 50% and sometimes more of all UTIs. Postmenopausal women also may experience senile urethritis, and this usually occurs in older women. It appears that these patients are unable to mount a fever or develop an elevated white count or costovertebral angle, CVA tenderness. So these patients may present with an unexplained fall or a change in mental status. And in addition to urinary burning frequency and urgency, these patients may complain of vaginal and vulvar itching and discharge. Physical examination reveals a dry, pale vaginal epithelium and eversion of the urethral mucosa, and senile urethritis responds to topical estrogen therapy. Consider UTI in any condition involving pain in the flank and back or pain in the abdomen and pelvis, and also consider cervicitis and chlamydia infections. They don't assume that a sexually active female with dysuria has a UTI without first excluding the possibility of sexually transmitted disease, related cervicitis, vaginitis, or pelvic inflammatory disease. UTIs in pregnancy have potentially adverse outcomes for both the mother and the fetus, so it's best to obtain a urine culture in all pregnant patients with suspected UTI. Pyuria and bacteriuria always are treated during pregnancy, regardless of whether symptoms are present. Patients with diabetes mellitus are at increased risk for complicated UTIs. Older patients who appear toxic are more likely to have obstruction complicating their UTI, so obtain a structural study to rule out this possibility. And here are your references. Now let's go into treatment. Treatment approach considerations. Of course, appropriate antibiotic treatment leads to significantly higher symptomatic and bacteriologic cure rates and better prevention of reinfection in women with uncomplicated cystitis. Of course, the negative consequences include the promotion of the development of antibiotic resistance in uropathogens and commensal bacteria, and adverse effects on the gut and vaginal flora. Evolving practice seeks to achieve good symptom control for uncomplicated acute cystitis while reducing antibiotic use. And here are some treatment for uncomplicated acute cystitis in women. We have nitrofurantoin, macrocrystals, or macrobid, 100 milligrams twice a day for 5 days. Avoid if early pyelonephritis is suspected. Some side effects to consider with these agents: headache, nausea, vomiting, diarrhea, urine discoloration, difficulty breathing, shortness of breath, or cough. Then we've got trimethoprim sulfamethoxazole combination, which is Bactrim or Septra. That's 160 milligram, 800 milligram combo twice a day for 3 days. And avoid if resistance prevalence is known to exceed 20% or if used for UTI in the previous 3 months. Some side effects to consider: rash and or other allergic type reactions. Again, nausea, vomiting, diarrhea, increased heart rate, confusion, or lightheadedness. Fosfomycin or Monurol, 3-gram single dose. Lower efficacy than some of the other recommended agents. Avoid if early pyelonephritis is suspected. And some side effects seen with fosfomycin: headache, nausea, vomiting, diarrhea, vaginal pain, itching, and discharge. Fosfomycin and nitrofurantoin macrocrystal should be avoided in patients with possible early pyelonephritis, and fluoroquinolones are reserved for complicated cystitis. Empiric antibiotic selection should be based on local resistance patterns. Limiting use of your trimethoprim sulfamethoxazole combo may be prudent in order to reduce the emergence of resistance organisms. So resistance to the trimethoprim sulfamethoxazole combo has been associated with concomitant resistance to other antibiotics, and because of the importance of maintaining the effectiveness of Bactrim for treatment of serious infections, German national guidelines no longer recommend this agent as first-line empiric treatment for uncomplicated cystitis. Okay, in uncomplicated acute cystitis in women, on average, women with cystitis who receive effective antibiotic treatment can experience symptoms longer than 3 days. Complete resolution of symptoms can require 6 days of treatment, and features that may require a more prolonged course of treatment include a history of somatization, previous cystitis, urinary frequency, more severe symptoms at baseline, and patients who respond to antibiotics do not require follow-up urine cultures. And without treatment, 25 to 42% of uncomplicated acute cystitis cases in women will resolve spontaneously. And even without effective treatment, the likelihood that uncomplicated acute cystitis will progress to pyelonephritis is only around 2%, which is low. Complicated cystitis in non-pregnant women. Complicated cystitis is associated with an underlying condition that increases the risk for therapeutic failure. And these are some of the underlying conditions: diabetes, symptoms for 7 days or longer before seeking care, renal failure, functional or anatomic abnormality of the urinary tract, renal transplantation, indwelling catheter stent, and immunosuppression. For complicated cystitis in non-pregnant women, for those patients who can tolerate oral therapies, oral treatment consists of ciprofloxacin or Cipro, 500 milligrams by mouth twice a day for 7 to 14 days, or ciprofloxacin extended release or Cipro XR, 1 gram by mouth daily for 7 to 14 days, or levofloxacin, which is Levaquin, 750 milligrams by mouth daily for 5 days. Now, some side effects to consider with these fluoroquinolones. The common side effects are nausea, diarrhea, headache, dizziness, lightheadedness, or trouble sleeping. And more serious side effects are tendinitis, tendon rupture, arthralgia, pain in extremities, gait disturbances, neuropathies associated with paresthesia, depression, fatigue, memory impairment, sleep disorders, impaired hearing, vision, taste, or smell. Patients who cannot tolerate oral therapy or patients with infection that is suspected to be due to resistant organisms should be treated with parenteral therapy, such as IV Cipro, 400 milligrams every 12 hours for 7 to 14 days, or Levaquin, 750 milligrams IV daily for 5 days, or ampicillin, 1 to 2 grams IV every 6 hours, plus gentamicin, 2 milligrams per kilogram per dose every 8 hours for 7 to 14 days, or Zosyn, which is piperacillin and tazobactam, 3.375 grams IV every 6 hours, or Doribax, or doripenem, 500 milligrams IV every 8 hours for 10 days, or Premaxin, which is imipenem cilastatin, 500 milligrams IV every 6 hours for 7 to 14 days, or meropenem, 1 gram IV every 8 hours for 7 to 14 days. Now, the duration of therapy, shorter courses, which are 7 days, are reasonable if patient improves rapidly. Longer courses, 10 to 14 days, are reasonable if patient has a delayed response or is hospitalized. Parenteral therapy can be switched to oral therapy once clinical improvement is observed. Some antimicrobial therapy considerations. Oral therapy with an antibiotic that is effective against gram-negative aerobic coliform bacteria like E. coli is the principal treatment intervention in patients with lower UTIs. For women with acute bacterial cystitis who are otherwise healthy and not pregnant, 3 days of therapy with most antimicrobial agents generally is more effective than single-dose therapy and as effective as the same drug administered for a longer duration. Exceptions are your nitrofurantoin, macrocrystals, and beta-lactams as a group. Cystitis in older women or infection caused by staph, saprophyticus, is less responsive to 3 days of therapy, so 7 days of therapy is suggested. Other antimicrobial therapy considerations. Nitrofurantoin macrocrystals has the advantage of taking resistance pressure off the much-used quinolone class, and nitrofurantoin, in a 2009 analysis by Olson et al., 29.6% of 176 urinary isolates with E. coli studied were resistant to Bactrim, and none was resistant to nitrofurantoin macrocrystals. Resistance to ciprofloxacin was 1.8% in first-time UTIs versus 11.8% in recurrent UTIs. So it's good to consider nitrofurantoin as a first-line agent for uncomplicated lower UTIs. Fosfomycin, a single dose of 3 grams with 3 to 4 ounces of water, is a good choice for therapy where available because of minimal resistance and propensity for collateral damage. Fosfomycin is approved by the FDA for single dose treatment in adult women with uncomplicated UTI caused by E. coli or Enterococcus faecalis, but it's been reported that the efficacy of that single dose fosfomycin is inferior to that of standard short course regimens, but a recent meta-analysis of 27 trials found no difference in efficacy between fosfomycin and other antibiotics for treatment of cystitis, and found that fosfomycin was associated with significantly fewer adverse reactions in pregnant women. Fluoroquinolones are highly effective in UTIs, but of course these agents have a propensity for causing collateral damage and should be reserved for important uses other than acute uncomplicated cystitis. IDSA guidelines recommend that fluoroquinolones be used as second-line agents for acute uncomplicated cystitis and as first-line oral therapy for complicated cystitis. According to IDCA guidelines, beta-lactam agents like augmentin, which is the amoxicillin clavulanate combo, ceftonir, cefaclor, cefpodoxime, proxetil, in 3 to 7 day regimens are appropriate second-line choices when other recommended agents can't be used. And the IDSA advises against using amoxicillin or ampicillin for empiric treatment because these agents have relatively poor efficacy and high rates of resistance. So adjunctive therapy, patients with intense dysuria can obtain symptomatic relief from this bladder analgesic, phenazopyridine, to be used for 1 to 2 days. Of course, avoid long-term use, since this agent may mask symptoms of therapeutic failure or recurrence. And of course, drink plenty of water. Hydration is the key to dilute your urine flow. And hydration is important to accentuate unidirectional clearance of bacteriuria, especially if an obstruction was relieved recently. And drinking cranberry juice, about 10 ounces a day, or taking cranberry tablets can offer some benefit in reducing recurrent UTIs and does not appear to be harmful. Cranberries contain type A proanthocyanidins, and this compound and its urinary metabolites interfere with the adhesiveness of uropathogenic bacteria to the bladder epithelium. Their effect is not as significant as antibiotics, but they do not induce bacterial resistance. So some alternative options, we have vitamin C. Vitamin C, of course, contains ascorbic acid, which can help to prevent UTIs. The idea is that vitamin C increases the acidity of urine, which staves off bacteria. D-mannose, it's a simple sugar that sticks to the bacteria E. coli to prevent UTIs, and a review published in 2020 found that D-mannose may prevent bacteria from clinging to the bladder and causing infection. And of course, more research is needed to determine the optimal doses and side effects. Vaginal estrogen replacement. Again, estrogen may also play a role in urothelial health, as well as in the autonomic and sensory innervations of the vagina. So recurrent UTIs are very common in postmenopausal women. The use of vaginal estrogen therapy is both safe and efficacious in lowering UTI risk. It is thought that estrogen increases the stores of glycogen on the surface of the vaginal epithelial cells, which is the vaginal lining, and glycogen acts as a food source for lactobacilli. And the more glycogen that's available, the more lactobacilli eat and the more they multiply. And abundant lactobacilli provide a lactic acid-rich protective environment. And when females go through menopause and the levels of estrogen are reduced, this food source also diminishes, and so do the lactobacilli and accompanying protective acid. So vaginal estrogen increases the presence of lactobacillus in the vagina in postmenopausal women, and the 2019 American Urological Association guideline for recurrent uncomplicated UTIs in women recommend that clinicians offer vaginal estrogen therapy to peri and postmenopausal women with recurrent UTIs to reduce their risk. And also, the guideline recommends vaginal estrogen therapy for women already on systemic HRT without an increased risk of adverse events with the added vaginal estrogen use. Systemic HRT has not been shown to improve risk of recurrent UTIs, but several randomized controlled trials of various applications of vaginal estrogen therapy have shown a decreased incidence and time to recurrence of UTIs in hypoestrogenic women. And these studies did not identify any form of vaginal estrogen that's clearly superior in reducing UTI risk or treating genitourinary syndrome of menopause symptoms. So the choice of vaginal estrogen formulation should be according to patient preference. And here just shows a healthy vaginal lining where there is a lactobacilli dominant environment. And once estrogen is reduced, we see more diverse bacteria here. And the vaginal lining has less glycogen, and so it's not as healthy. And here are some vaginal estrogen formulations that are available. Of course, the conjugated estrogen cream, estradiol cream, tablets, inserts, the ring, and of course, compounded vaginal estrogens, which can be more customized according to the patient's needs, cream or suppositories. Okay, and here are some preventive measures. Prophylactic measures are indicated for patients with recurrent UTIs, spinal cord injury, urinary catheters, and renal transplants. Increased fluid intake is a must. A study of 140 women with recurrent UTIs showed that increased fluid intake reduces the risk for repeat infections. The study participants were otherwise healthy premenopausal women who had experienced 3 or more UTIs in the preceding year and who self-reported low fluid intake, which is about less than 1.5 liters a day. Sexually active women may attempt voiding immediately after intercourse to lessen the risk for coitus-related introduction of bacteria into the bladder. Minimize douching, powders, sprays in the genital area, wiping from front to back, take showers versus baths, prophylactic regimens for women with frequent recurrent UTIs, like postcoital or continuous antibiotics. Women with fewer than 3 UTIs per year may benefit from self-initiated antibiotic therapy. In a 12-month randomized study of 28 women with recurrent bacteria cystitis, treatment with intravesical hyaluronic acid and chondroitin sulfate significantly reduced cystitis recurrence and improved urinary symptoms, quality of life, and cystometric capacity as compared with antibiotic prophylaxis. And the intravesical treatment was given once weekly for 4 weeks, then once every 2 weeks, twice more. And antibiotic prophylaxis consisted of sulfamethoxazole and trimethoprim once weekly for 6 weeks. So here are your key takeaways. Urinary infections are very common in the US. They're the second most common bacterial infections. UTIs are most common in women, mainly due to the female anatomy. The main pathogen responsible for both complicated and uncomplicated UTIs is E. coli. 2 main types of UTI infections: bladder infection or cystitis and kidney infection, pyelonephritis. Short-term or long-term antimicrobial therapies are dependent on the type and severity of the infection, and preventive measures are key to deterring bacterial proliferating in the urinary tract and causing an infection, which can lead to pain as well as persistent and sometimes severe complications, resulting in potential kidney damage. Here are your references, more references. Thank you for joining us today, and please connect with us. We are a national network of 503A and 503 compounding pharmacies providing innovative and quality pharmacy preparations and services through industry-best patient care and solutions for customers and healthcare professionals. We're here to help you to help your patients with programs like Consult RX, which is a nationwide VIP service for clinical consulting, with our functional medicine and anti-aging board-certified team of clinical pharmacists and practitioners bringing a combined 50-plus years of experience to provide the highest level of service possible. Please join us for another informative webinar coming soon.